Okay, Queen, go ahead.
We are going live in next 10 seconds.
We are
10,
live. Amit, start.
9, 8, 7, 6, 5, 4, 3, 2, 1. We are live now.
Good evening, everyone, respected seniors and dear friends. Today, we welcome you all to this wonderful webinar, which is one of its kind, because for the first time, Foxy Sexual Medicine Committee and Endocrine Committees have joined hands to bring to all of us this wonderful session. And we will be talking about the sexual health, specifically the endocrine aspects. And for of stars who will be enlightening us with their knowledge so that we get to know more of these aspects which are hardly discussed and spoken about. So right at the beginning, I would like to invite none other than Dr. Neeraj Jadhav sir, the chairperson of Foxy Sexual Medicine Committee. And at this moment, I would like to take the opportunity to congratulate sir and the entire team. I'm also a part of the team, but sir specifically for everything that he has done for this committee and made it the best committee for session. And we are also proud of you and congratulating you once again. Sir, please take over.
Thank you, Queen. So, good evening and welcome for today's webinar that we are a Sexual Medicine Committee is jointly doing with the Endocrine Committee of Foxy. So, friends, we all know how important are hormones. Hormones are responsible for all our activity. So, it also includes the sexual function. So, it's a very interesting webinar today because we are dealing with the going to learn about the how hormones and the sexual functions correlate and how disturbance in the hormones lead to the sexual dysfunction. Our body produces hormones to regulate all our body functions from sleep cycle to our sexual health. And when our hormones are off, our sexual functioning and health are thrown off as well. Hormone imbalance can lead to sexual dysfunction both in male as well as in female. Like much in medicine, there is a very interesting history behind the how hormones came to play in sexual medicine. Someone accidentally stumbled upon the link between the reproductive hormone and the sexual desire. Testosterone was the first isolated and synthesized in the 1930s and started getting prescription for a wide range of conditions. Some women who were taking doses of testosterone that far exceeded what is considered normal, they noticed that there's some pretty unexpected side effect like facial hair growth, deeper voice, but some also noticed increase in the sexual desire. And just like that, the myth that the testosterone is a prime driver of the sexual drive in women was born. Over the next 30 to 40 years, we got more insight into how testosterone and estrogen across the menstrual cycle, how they change, relate to the psychology and the behavior as well as the how they affect the sexuality in general. In the last 20 years, there have been influx of the studies and seeing how those correlate with the sexual behavior and with the sexual desire. So I'm very excited to know about this aspect of the sexuality, that is about the hormones and how they play a vital role in the our sexuality. So we have so many experts today who will going to teach us about the role of hormone in male sexuality, in female sexuality, as well as in the adolescent. And we have also one talk by on the somatogenesis as well as on obesity and how it leads to the various sexual dysfunction. So like all of you, I'm also eager to learn. And once again, I welcome every one of you for today's webinar. And I hope you will get so many knowledge after attending today's webinar. So welcome once again. Thank you. Thank you. Over to you, Queen.
Thank you so much, sir, and thanks for the overview. And now next, I would like to invite our dynamic chairperson of the Foxy Endocrine Committee, the very beautiful Dr. Rakhi Singh. Ma'am, please take over and enlighten us with a few pearls of wisdom from you. Thank you.
Thank you, Queen. And here I come bringing you greetings from Foxy and President Foxy, Dr. Rishikesh Pai. Vice President of my committee is Dr. Gitendra, and Vice President for Neeraj is Dr. Asha Bakshi ma'am, both of them who are there with us, and Secretary General of Foxy, Dr. Madhuri Patel. And as it is, Neeraj has highlighted very nicely that the hormones are the important key factors for us to work and for all the balanced work which has to be done. They are like the precursors for any normal functioning of the body, and without the hormones nothing works, because as it is they are all important for any of the body function which has to happen. And here we are there with us. We've got all the star-studded faculty with us to enlighten us on the sexual aspect of the hormones. There are various hormones which are happy hormones. There are various hormones which act on the HPO axis and the hypothalamo-pituitary testosterone, that is testis axis also, which are very important and to govern and understand how they help us in our making of the babies and how they help us in the sexuality, which is one of the main factor for the functioning of the life, which is important for all of us, for the generations to come and generations to move ahead. So here, without wasting much amount of time, let's move on ahead with this program, and with the lovely basket of star-studded faculty which we have today, let's understand the sexuality and the hormones, the connection between both of them. Over to you, Queen.
Yes, thank you so much, dear ma'am, for your kind words. And next, we would like to start the program by inviting our seniors from Foxy, our president, sir. Has sir joined?
No, sir is in airport. Sir will join and then we'll.
So is Madhuri ma'am there?
Madhuri is also out of India and she will try to join. No. Okay. Asa madam is there, so invite Asa madam.
Yes. So Apurva has joined, so let him take over.
Yes, ma'am. Yes, ma'am. I am there. So I welcome all of you for this unique webinar, which we are, with the guidance of our president, we started it with the theme of Badlav. First time the endocrine committee and the sexual medicine committee comes together for this unique webinar. So I would like to invite our very senior, our vice president in charge, Dr. Asha Bakshi ma'am. Ma'am doesn't need any introduction. Ma'am is the vice president, West Zone Foxy, and just recently we had a wonderful webinar organized by Asha ma'am in Indore, and really we enjoyed it a lot. Thank you so much, ma'am, for always being with us, for always your guidance and for always your blessings. Over to you, ma'am, for your kind words. Yeah, Asa ma'am, over to you.
Madam, you have to unmute. Asa madam, you are muted.
Yes, ma'am, you are muted, ma'am.
Thank you very much, Apur, for the kind introduction. It was not a webinar, huh? It was a live physical conference. And to do live physical conference these days is very, very difficult. So just I wanted to remind you. Anyway, thank you so much. And this committee, the sexual committee and the endocrinology committee, the Sangam is really very good, and we know that sexual committee cannot survive without the support of endocrinology, and it's vice versa. And both the branches need support of each other, and you need knowledge of both the branches. So I think it's a very good amalgamation. And we have very good speakers, so I'm sure there would be lots of learning points, and we'll all enjoy. So, and I'm really glad that Neeraj is doing lots of activities and getting accolades from everywhere, the best committee award, and now again, I'm sure he's going to get something more, and already Dr. Rishikesh Pai has said that he's already a vice president candidate. So these are very good accolades that you have got. And Rakhi, you are already doing such good work, your newspaper and your webinars. really very brainy. Whatever you are doing is really very good, and thoroughly enjoying that. And especially, it will be a collection for lifetime. So that's the best thing out of it. Queenie, thank you very much for organizing this webinar. And as usual, Apurva पूरा छाता रहता है हमेशा. Madan Kamini, I
Thank you
can't
so
see him
much.
there, but he's always there. Hi, Ankur. And I think Dr. Vani Puri was there initially. So nice to see her. Hi, Hitendra. Nice to see you as well. And I'm sure you can continue. Dr. T.S.S. Rao, आपको भी बहुत-बहुत pranam. Or let's continue. Dr. Vasan, hi. I think you are in the car. So let's continue with the program so that all these webinars also need to be, I think, now very crisp so that people know that, oh, within 1 hour, I will be free and then I'll continue. Because like we are talking, and I think that is also wasting a lot of time. So we have to really respect other people's time as well. Thank you so much.
Thank you. Thank you so much. Thank you so much, ma'am, for always being there, for always your blessings, your advice, and your kind words. Moving to the next, our next guest of honor is Gitendra sir. I think sir is not
he's
there.
not there. Apurva, just you can start the program.
Yes, yes, yes. Ma'am,
Queen, invite
Yes.
Vasan sir.
So yes, without wasting time, we will invite our first speaker, Dr. S.S. Vasan, who is a uroandrologist, MBBS DNB surgery, and with a fellowship in andrology and incontinence from Singapore. And he is the head of the Andrology Fellowship Program, Rajiv Gandhi University for Health Sciences, and he is the program director for MH Pro, an online medical learning portal, and has several accolades to his credit. And without wasting time, sir, please start your wonderful talk about hormones and male sexuality. Over to you, sir.
Thank you, Vasan sir, for joining us from your busy schedule. We know you how busy you are, but giving time to us for your talk. Thank you very much. Over to you, sir.
Good evening, everyone. And, my sincere apologies because I was planning to be home by 7, but I was asked to become the first speaker. I was supposed to be the third speaker, and suddenly I was shifted to the first speaker, so I couldn't readjust my schedule. So that's why I'm traveling in the car, and you know, in Bangalore it takes a time to reach home. So,
Sir, there is a lot of disturbances by air. I think.
Is it okay now? Is it okay now?
yes, 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 sir. Yes, sir. It is okay now.
Okay. So what I was saying is that my lecture was supposed to be the third, and suddenly I got pushed to be the first lecturer. So somewhere down the line, I couldn't adjust my schedule for that. Anyway, I will take you through what I believe is what is hormones and male sexuality. As we all know, there are a lot of aspects to male sexuality. When you talk about sexual function, it starts right at the level of the embryonic development, where we believe there are certain hormones which are primarily necessary, among which you have testosterone, your AMH,
Sir, we can't hear you because I think there is some network issue.
which primarily drive male. Oh, I'm sorry. You can hear me now?
Yes,
Can you hear me?
Yes, sir. Now you're audible. Yes, sir. Now you're audible.
Maybe I'll just shut off my
Sir,
video.
maybe you can off your video and
Yeah,
then
that's what.
speak.
Yeah,
That
yeah,
would be
yeah.
better.
That's what I was just thinking of. So I will just do that. Just give me 1 minute. One second. Can you hear me now?
Yes, yes, sir.
Yes, sir. You are.
Is it better?
Yes, sir. Better.
Hello?
Yes, sir. Yes, sir.
Hello?
Yes, sir. We can hear you.
Okay. So, okay. So, anyway, the development starts at the level of embryonic development, which we are all aware of is a very complex process involving your Wolffian ducts, Mullerian ducts, and there are a lot of hormones involved, even in this stage of fetal development. And the importance is the primary hormone driving this development is the male hormone testosterone. And secondly, we also know that sexual behavior in both sexes is strongly regulated by circulating concentration of gonadal steroid hormones, primarily androgens, which is testosterone, to an extent estrogens, which is estradiol, and your progesterone. And sexual behaviors are often conceptualized into two categories, which is your appetitive sexual behavior, which is your sexual motivation, and your consummatory sexual behavior, which is your actual act of sex. So, unfortunately, sexual performance is not limited to only the erection phenomena. It is also encompasses several other aspects which needs to be in proper the person has to be in proper mood, there has to be a spontaneous desire, there has to be an appropriate sexual stimuli, and consequently there are a lot of biological factors which play, means that the mind's information processing along with psychological factors are extremely essential for the subjective arousal and the autonomic response, which, if it is proper, creates more arousal and more triggered desire, and consequent to that there is sexual satisfaction and other goals of sexual performance in terms of increased emotional intimacy and well-being are also achieved. So the primary aspect is not just a hormone which drives it, it's also to bring in the point that hormones have a role to play, but it is the mind which controls a lot of things, wherein environment, the person, the way you dress, even sense of smell, all these becomes important. And so these are the various areas in the brain, primarily appetitive behavioral areas, and you have primarily consummatory behavioral areas. As you can see, brain is triggered in lot of areas for the appetitive, primarily appetitive area, which is your desire area. So desire is a primary driver for sexual activity. I hope you can still hear me.
Yes, sir. We
Yes,
can hear
you're
you.
audible.
Yes, sir.
Okay.
Yes, sir.
So there are different hormones which are described to facilitate this appetitive area. So only when the appetitive area gets triggered, then you have the hormones coming into play, and primarily you have the sex hormones or the non-sex hormones. And in the male, it is primarily the testosterone, and both in male and female, you have some amount of hormone which is produced by the pituitary gland, which is your growth hormone, your thyroid gland, thyroxine, pancreas, which is insulin, and adrenal gland, which produces adrenaline. So this is a complex mechanism. We are all aware of this. I'm sure as reproductive medicine specialists, most of you are aware of the hypothalamic pituitary axis and the various hormones involved in the interplay and the final production of testosterone. I'm not going to go into this in this brief lecture. Now, why is testosterone important? Because at the end of the day, the testosterone controls several functions, which is your not only your libido, it increases muscle mass, it increases body hair, it has a role on bone strengthening, it has a role on sperm production. So it's not a hormone only for sexual development. One of the aspects of the hormone is sexual development, but it is overall for your muscle, and it is for memory, concentration. So it has a gamut of functions. So testosterone role in sexual activity alone cannot be perceived as the primary reason for this hormone being present in men. It is also for several other aspects which help overall development of the male. So testosterone in the sexual organ, it produces, what does it do? It produces enlargement of the penis, and it produces enlargement of the testis. There is an amount of increased libido, primarily if the psychological factors are conducive. Testosterone is primarily a driver of to an extent of libido, not exactly an erection. It increases the libido, and it also facilitates secondary sexual characters in terms of masculinity, where you have the male pattern of hair, which is your face, chest, axillary hair, gluteal hair, which will all give you the semblance of manliness, which is the production of testosterone. Then you have the reproductive aspect of testosterone, because as we all know, the hormone which testosterone is produced by the Leydig cells, and which is controlled by the LH, luteinizing hormone, which is produced from the pituitary, and interstitial cells are primarily responsible for the testosterone production, which have an effect on the sustentacinal cells of the seminiferous tubules, which we all know primarily produces the spermatogonia. And so consequently, testosterone has a primary role to play in the development of reproductive organ, as well as in secondary sexual characters, plus spermatogenesis. And this is the reason why testosterone is a comprehensive reproductive hormone in men, where it has a role to play not only in organ development, in desire, motivating the individual, manliness, as well as in the form of reproduction. Hello? Can you hear me?
Yes, sir. Yes, sir. There were some disturbances. It is okay.
Okay, so this is a slide which highlights the various aspects of testosterone, where it has an effect on the mind, it has an effect on the body, it has an effect on other aspects of sexual function. So the testosterone production is influenced by several factors, both exogenous and endogenous. Exogenous factors are your stress, diet, weather, sexual stimuli, physical activities, whatever it may be, mild to moderate aerobic exercise stimulates testosterone, and of course your hormonal supplements and some of the medications you take for contraception. Endogenous factors are the production of testosterone itself. As we all know, testosterone is primarily produced in the testes, but you have about 5 to 10% coming from the adrenals as well. And the degradation, the extent of degradation and the metabolism of testosterone, which is driven by the exogenous factors, and conversion of testosterone to estrogen or DHT, which is variable depending on the fat in a given individual, and SHBG level. And then you have genetic variability, age, emotions, thoughts. So it's a complex hormone which is driven not by a secretory gland. That means you have your certain glands like thyroid, which produce thyroxine, and you have insulin being produced by the pancreas at a steady pace, whereas testosterone is dependent. That's why you have what is called as a diurnal variation, and it has peaks and troughs where it is produced in different concentrations at different points in time. Now, what are the challenges of underproduction of testosterone? Basically, you land up in what situation called metabolic syndrome, where you have increase in inflammatory biomarkers, lipotoxicity, insulin resistance, and consequently endothelial dysfunction. Now, endothelial dysfunction per se is narrowing or inflammatory changes of the lining of the blood vessels, which leads to vasoconstriction, arterial stenosis, oxidative stress, thrombosis, inflammatory cell addition, endothelial permeability issues. So consequently, it causes primarily decrease in blood supply, oxygenation of an end organ. And which are the primary end organs it facilitates or supports? The primary end organs which it facilitates or supports are the testis and the penis. So in both these, if testosterone is deficient or is produced not adequately, then you have all these cascading phenomena which happens, and consequent to that, both these organs suffer either apoptotic damage or hypooxygenation, which leads to some amount of blood flow issues and inflammatory cell additions and cell permeability issues. So as I just now said, testosterone is a primary mediator of the endothelial function, the nitric oxide level, which is necessary to induce a penile cascade of oxygenation, which is necessary for vasodilatation, which facilitates inflow of blood into the corpora cavernosa. As we all know, corpora cavernosa is supplied by the cavernosal and helicine arterioles, which are the final terminal branches of the cavernosal artery, and they require to be in a vasodilatory state for you to get a proper erection. If they go into a vasoconstrictive state, then you get a detumescence or a flaccid penis. And the facilitation of a vasodilatory phase is done by the testosterone by ensuring that there is adequate supply of nitric oxide in the endothelium of the blood vessel, which is your cavernosal artery. And the hypogonadal states lead to low levels of nitric oxide, leading to chronic deoxygenated state. And this is what happens. And testosterone levels, when it is low, that is why you have predominantly penis as an organ is only oxygenated probably for about 10 to 15 minutes in a day, predominantly for more than 24 hours and probably 45 minutes, at 23 hours and 45 minutes, it's in a deoxygenated state. And that is primarily reason why, because testosterone has this diurnal variation, and consequent to that, it is primarily dependent on that. So to look at how does it impact as a clinician, what you need to know is, we all know that hormone wise, for sexual function and for reproduction as well as for development, you require testosterone. Now, what are the consequences of delay or lack of production or underproduction of testosterone? So one of the challenges is always that delayed puberty, and this you need to be very clear. How do you diagnose? One is to look at bone age, but we go by other criteria, because first of all, you need to exclude certain conditions which can delay puberty in the form of celiac disease, Crohn's disease, excessive physical activity, steroid abuse, and so on and so forth. But in boys with a testis of less than 4 ml at 14 years of chronological age, and if the bone age is less than 13 years old, at that it is a sign of delayed puberty or hypogonadism. If bone age is more than 13 years old, then it's a sign of hypo or hypergonadotropic hypogonadism. So essentially, you do your FSH and LH, testosterone and estradiol, estradiol in case of women or girls. In selected cases, you also do inhibin B, GnRH test, HCG test, karyotype, and so on and so forth. So you try to diagnose on the basis of low LH and low testosterone to classify it as hypogonadotropic hypogonadism. So this is the slide which is most important, because delayed puberty is the first sign of hypogonadal state of a child, and other than you have various classifications to decide clinically whether there is a delayed puberty, and the classical staging we use is what is called as Tanner staging, which is 1 to 5, which is dependent on several aspects of growth as well as testicular volume. You can do biochemistry, bone age X-ray, basal FSH, LH, IGF protein, prolactin, testosterone, and so forth. So the working diagnosis is always normal growth rate for bone age, slow growth rate for bone age, and third aspect is elevated FSH after 13 years in girls or 14 years in boys. When you have this is constitutional delay in growth in children, which is or because of GnRH deficiency, where you find normal growth rate for bone age. Slow growth rate for bone age is functional hypogonadotropic hypogonadism. If it is it can be associated with low BMI, normal BMI, or high BMI. If it is a low BMI, you classify it as a GI disorder or underfeeding. If it is a normal BMI, you classify as a hypothyroidosis or hyperprolactinemia or gonadotrophic GHD deficiency. And high BMI is always iatrogenic, usually because of corticosteroids. If it is elevated FSH, it is primary hypogonadism in boy, and usually you need to do karyotyping, which is very, very crucial in this kind of individuals. And then I'm not getting into the treatment, but just to give you an algorithm of how do you manage these boys. Now, in children, we have not been able to yet define what is exactly a cutoff of low testosterone. It is very difficult. That's why I didn't talk about testosterone value in children. It is very difficult to talk about that, but we can talk about adults. Or in adults, we know that when do we measure testosterone? We measure morning testosterone levels, and we measure, just give me another 5 minutes. I know I'm trying to exceed my time. I'll just finish it. If it is low, it is considered low testosterone. If it's less than 300 nanogram per dl, it is normal. If it is more than 300 nanogram per dl, and if it is low, then you remeasure one more time morning testosterone, reclassify it if it is low or high, because testosterone has a diurnal variation. And if it is persistently low, either you treat it or you refer to an endocrinologist, because it's classical hypogonadism when it is low. Now, history and physical symptoms, like I said, on the basis of history and physical symptoms, you decide whether there is a evidence of low testosterone in the form of tiredness, concentration defects, memory, irritability, loss of muscle mass. There are various. You have what is called as Adams sign, which is a wherein you can calculate the degree of hypogonadism on the basis of physical symptoms a person is undergoing. So once you have, you measure the morning testosterone and you establish that there is low testosterone, then the treatment usually depends on excluding reversible illness, drugs, nutritional deficiency, and repeat testosterone use of but then you start whether you want to treat it or not. Once you confirm low T, then you can also do free or bioavailable testosterone. And if it is low testosterone with low normal LH and FH, then it is secondary hypogonadism. If it is low testosterone with high LH and FSH, it is primary hypogonadism. In primary hypogonadism, we always do a karyotype to rule out Klinefelter syndrome. Of course, you will have the obvious features of Klinefelter's, which is a tall individual with broad arm span, and so on and so forth. And of course, with in classical secondary hypogonadism, you can measure prolactin, iron, and other pituitary hormones, MRI under other certain circumstances. And so this is the general algorithm for managing hypogonadism. And in nowadays, we are reclassifying the low values as to there is a borderline range which is being created nowadays. This is the latest method of measuring testosterone, where we think that the lowest value of classical hypogonadism should be less than 230 with elevated FSH-LH or low LH and FSH, and borderline is between 231 to 346, and normal is above 346. So there are various algorithms which are being built for testosterone. There's a lot of research going on in testosterone. It's the most used and abused hormone among all the entities we know in terms of measurement. So to summarize, testosterone is a wonder drug for many people because it is used in multiple indications. You can increase muscle mass, where it is abused by all of these sportsmen. At the same time, it has a crucial role to play in both reproductive as well as in sexual function. So as this slide shows you on the left side, this is where it acts on the reproductive sexual function, where it regulates nitric oxide expression, regulates nerve structure and function. So it has a gamut of functions if it is proper in a given individuals. Low subtle doses do help set testosterone, but we should also bear in mind testosterone in an individual who's looking to have a conception is a dangerous drug because it can suppress spermatogenesis. Similarly, it has a system which is one of the areas where it predominantly works by increasing arousal mechanisms, and it has an effect on amygdala, hippocampus, and parahippocampus. So this is the way testosterone is structured. So to summarize my lecture, in terms of sex hormones and sexual function, I think sexual function is primarily driven by testosterone, but we need to understand testosterone as a drug cannot be randomly used. It needs to be first evaluated, understood whether there is a deficiency of testosterone, and that is what is driving the individual in terms of his sexual dysfunction, or is it other factors which is causing the sexual dysfunction. So proper understanding of testosterone, proper measurement of testosterone, proper use of testosterone is extremely crucial. Thank you very much, ladies and gentlemen.
Thank you, sir. It was such a enlightening topic, and you delivered us in such a simple way that because for us as a gynecologist, it's sometimes difficult to understand all this male aspect. Oh, yes, Queen.
Yes. Thank you so much, sir, for enlightening us. Now, Apurva, are you there?
Yes, ma'am. Yes, ma'am.
Yeah.
I'm
So
here.
then now, you please take over and invite Sanjay, sir.
After this wonderful
Vasan sir, can you
lecture,
stop sharing? 1 minute.
Yeah. 1 minute. Sorry. Yeah.
Yeah. Okay, sir. Thank you.
after this wonderful lecture by Vasant sir, and that too inside the car while driving, it's really made our testosterone at a high level. So thank you so much, sir, for this wonderful lecture. Now I would like to invite Sanjay Deshpande, sir. Sir doesn't need any introduction. Sir is the immediate past president of CSCPI. Sir is the past son of IMA branch of medical specialist. Sir is the past president of the IMA branch of Maharashtra and whatnot. Sir, thank you so much for accepting our invitation. Over to you, sir. We all are really waiting to learn from you. Over to you,
Thank you,
Sanjay, sir.
Sanjay sir, for joining us and giving your time.
Unmute yourself, Sanjay, sir.
You have to
Sir,
unmute,
please,
sir. You are muted, sir. Sanjay sir, you are muted. Yeah.
So can you hear me now?
Yes, sir. Yes, sir.
yes, sir.
Yeah.
You're audible.
So thank you, Apurva, for a very nice introduction. In fact, I am a simple man, and it's always to be simple because you study the female sexuality, or when you study female as such, you know that how difficult it is. And I am talking in front of all those stalwarts, those who know female very well than me. So basically, when I say that I am a sexologist, just few words that we usually cater to males rather than females. And I can definitely tell out of my 1,000 patients, there must be 999 males and one female, because most of those females are taken care in a very effective way by all of you gynecologists. So thank you very much. Whenever I'm invited by any gynecology association, I always say yes, because I remember that my mentor or my teacher, my guide, my philosopher, Dr. Mahindra Vatsa, was also a gynecologist. So salute to all of you. In fact, it's a very difficult topic given to me, because I say to study a woman, to know a woman is very difficult. And sexuality is a very, very intricate and delicate matter. So at the outset, I must thank Dr. Neeraj for involving me in this very important endocrinal as well as sexual update. I will just share my few experiences with all of you. Kindly bear with me. So as we know that sex hormones are the hormones, but there are many functions of sex hormones. It's not only sexual function which is important, but apart from sexual functions, they are important for many other functions in males and females. We'll be involving or restricting ourselves only for female sexuality here. So it is important for puberty and sexual development, reproduction, sexual desire, regulating bone and muscle growth, inflammatory responses, regulating cholesterol levels, promoting hair growth, body fat distribution, and very importantly, endothelial function is also very important function of this all sex hormones. And in both, because we say that estrogen gives protection to a woman against coronary artery diseases. Same thing is true with men also. Nowadays, there are ample of evidences that testosterone is also supporting a man for his cardiac health. So sex hormones usually, they are like untouchables in the whole medicinal, what you can say, area, that we say that sex hormones are only to be used only when there is need for any sexual problem. But it's not like that. They are important in other aspects of life also. Now, as we know, sex hormone fluctuate throughout a person's life, and especially a woman. Means during 1 month also there may be a lot of fluctuations of sex hormone in a woman, and that's why it's very difficult to understand the role of hormones and the sexuality in case of females. Now, factors that can affect the level of female sex hormones is age. Because as we know, after the menarche till menopause, the hormones are high in nature, high in level. So as the age is beyond this reproductive age group, there may be some disturbances in female sexuality. Menstruation, even menstrual cycle also, during all the phases, the hormones are fluctuating. Pregnancy, menopause, stress, obesity, medication, and the whole environment. So these are all the factors which actually affect the level of sex hormones in females. Now, these are the various sex hormones. I especially wrote oxytocin and vasopressin because there is some role of these two hormones in the female sexuality. May not be actually in female functioning of reproductive system, but in sexuality is important. Now, both estradiol and testosterone have been implicated as the steroid critical for modulating women's sexual desire. There are many research is going on for reproductive health and testosterone as well as estrogen. Estrogen, all of us know, but testosterone is basically over-sensationalized for even female dysfunctions also. Studies demonstrate that estrogen-only therapies that produce peri-ovulatory levels of circulating estradiol increase the sexual desire in post-menopausal women. 1 minute. And testosterone at supraphysiological but not as physiological levels enhances the effectiveness of low-dose estrogen therapies at increasing women's sexual desire. There are many contradictory and confronting evidences in the literature, and that's why I'm wanting to put forth all these evidences in front of you. The ovarian steroids, which are estradiol, testosterone, and progesterone, modulate sexual desire or libido in women. The gradual and age-related cessation of ovarian function associated with natural menopause decreases the level of ovarian steroids, which is accompanied by diminished sexual desire in a significant proportion of post-menopausal women. Similarly, women who undergo bilateral oophorectomy, surgical menopause, routinely report a post-operative decline in sexual desire after experiencing an abrupt and pronounced drop in circulating levels of ovarian hormones. Now, this is very important observation found in one study that roughly 9% of naturally and up to 26% of surgical postmenopausal women suffer from a persistent and distressing lack of sexual desire. Now, this is a wonderful observation which can be elaborated that only 9% of naturally postmenopausal women against the 26% of the surgical postmenopausal women suffer from persistent and distressing lack of sexual desire. Now, this is something to be discussed about. Means only hormones are not important. There are many other co-founding factors which may be responsible in the functioning of sexuality as well as functioning of the sexual relationship in a woman. Now, these hormones do not create sexual desire, but women's sexual desire is clearly subject to hormonal influence. The identity of the ovarian steroids, critical for modulation of women's sexual desire, however, remains a topic of debate because there are a lot of controversies. Some says estrogen is most important, some says testosterone is more important. There was one study which demonstrated that ovarian steroids had little impact on female sexual functioning and that adrenal androgens critically modulated women's sexuality. Now, women provide us greater opportunities to study the relationship between reproductive hormones and sexual behavior because we are more focused on sexual behavior. Changes in hormonal levels are experienced during menstruation, pregnancy, and menopause. Surgical procedures removing the reproductive organs is much more common than a man. That's why it's a complex thing in women. Enormous hormones are prescribed to women either for contraception or for hormone replacements or even during treatment of infertility. Endocrinal abnormalities are also more common in women, and that's why it is difficult to understand the inconsistent and contradictory results. If you take menstrual cycle, now sexual activity and sexual interest during menstrual cycle is not consistent. There are few inconsistent results in many studies. Some studies state it is premenstrually women have high desire of sex. Some say it is post-menstrually, and few says that it is during menstruation, and few around the time of ovulation. But most predominantly, some say that it is during the premenstrual or pre-ovulation period. Now, ovaries were the primary source of estrogen in women. Level of circulating estradiol increased steadily throughout the follicular phase of menstrual cycle, which peaked at mid-level roughly 24 hours prior to ovulation, and subsequently it decreases and remained at the mid-follicular level throughout the luteal phase of menstrual cycle. Now, studies that directly assess women's sexual desire revealed predictable variation in relation to the hormonal fluctuations of the menstrual cycle. There was a study, huge study, involving 22,365 menstrual cycles of women, found a striking mid-cycle peak in the occurrence of women's self-reported sexual desire. So it is during a pre-ovulatory. But there is another study, a very interesting study. The researcher asked 69 women to fill out the daily questionnaire concerning all heterosexual and autosexual behavior, and found that participants reported a significant mid-cycle peak in the rates of masturbation. Now, because it was both heterosexual as well as autosexual or solitary sexual activity. And interestingly, heterosexual behavior initiated by the participants themselves actually decreased at mid-cycle. Now, why? Because none of these women were using a reliable form of contraception, and 87% of these women reported being aware of an increased risk of pregnancy at mid-cycles. And that's why he concluded that mid-cycle increase in autosexual but not heterosexual behavior reflected a mid-cycle increase in women's sexual desire combined with a concerted effort to avoid pregnancy. So women's sexuality, women's sexual desire is not related to only hormonal status. The expectation of women, the expectation from a woman, the expectation from the society, her own issues, pregnancy, menstruation, all these jointly affect the sexuality or sexual behavior of a woman. The same authors examined the relationship between self-reported levels of sexual desire on a given day and steroid hormones levels on that same day, and 1 day and 2 days prior to that day. And what they found, that estradiol was significant positive factor for sexual desire measured 2 days later, while progesterone was a negative predictor. And by contrast, testosterone did not reliably predict the women's sexual desire at any point of time. So again, previous studies said that estrogen is not a predictor, but testosterone is predictor. But there are contradictory evidences in literature. There is a little support for the notion that testosterone is the critical libidinal hormone for women. The likelihood that an androgen-only clinical state treatment will meaningfully increase women's sexual desire is minimal, and the focus of pharmaceutical companies on the development of androgen therapies for the treatment of female sexual desire disorders is likely misplaced. Given that elevated estradiol levels within physiological range increases women's sexual desire, without concurrent androgen therapy, the use of supraphysiological testosterone to treat the low sexual desire in women may be inappropriate. In fact, as a sexologist, I can say that the only hormonal treatment for increasing the sexual desire is always insufficient. There are many other issues which also needs to be focused. Now, studies showed that focus on establishing threshold levels of estradiol required to be reliably produce a meaningful increase in the sexual desire in post-menopausal women. We have to go for different treatment and dose effective regimes also. And whether the safety concerns about exposure to elevated estradiol can be addressed via novel steroid formulations or treatment regime should also need to be investigated. In pregnancy and lactation also, there are many fluctuations in hormones as well as in female sexual desire. There are massive changes in hormone levels during pregnancy and lactation. The majority of women show a decline in pregnancy as pregnancy continues. Masters and Johnson found an increase in sexual responsiveness in second trimester, because many times that is what is a safe period considered by a woman, that she may be enjoying sexual intercourse at that time. But what happened, it was found that a decline in the first trimester was only found in first pregnancy, in primary, while in subsequent pregnancies, there was no significant decline during first trimester also. But still, it's a fact that sexual activity and interest reduces for several months during pregnancy and lactation. Now, some women enjoy the erotic sensation during breastfeeding, because breastfeeding can increase the oxytocin level, pleasurable sensation. Some say that it also gives the sensation to a woman at her clitoral level, and because of that, she also feels good about it, and that's why sexual desire increases. But many women feel guilty about it, that I am breastfeeding my child, and how can I desire about sex? So that creates a guilt in her. So it's both ways. Even oral contraceptives also, it's not sure whether that will increase the desire or not. But some women enjoy due to absence of fear of pregnancy. So fear of pregnancy also is one of the very important indicator in sexual desire of a woman. Now, interpretation of relationship between hormones and female sexuality. The sexuality of women is more susceptible to the effects of social learning than a man. Woman is more inhibited. Woman is more controlled than a man. So to experience a sexual pleasure, to experience the sexuality in full force of everybody, not a woman, but a man, you need to be out of control. You need to be uninhibited, and then only any person can enjoy sex. It is always said that whatever the sexual problems in women, they are due to inhibitions, and whatever sexual problems in men, they are because of high performance pressure, either by the society or by the man himself. There is always conflict between different behavioral effects of hormone, confounding effects of psychological factors, as I am mentioning every time, and greater variability in hormone behavioral relationship. Now again, oxytocin and vasopressin, why they are important? The hormone oxytocin and vasopressin are implicated in regulating both male and female sexual motivation. Oxytocin is released at orgasm and associated with both sexual pleasure and the formation of emotional bonds based on the pleasure model of sexual motivation. I always say, we human beings, we do the things more which pleases us, or in which we are successful. So if sexual pleasure model is taken into consideration, whatever pleases me or whatever pleases a woman, she will do it more. So increased sexual pleasure that occurs following oxytocin release may encourage motivation to engage in future sexual activities. Emotional closeness can be especially strong predictor of sexual motivation in females, and insufficient oxytocin release may subsequently diminish sexual arousal and motivation in females. High levels of vasopressin leads to decrease in sexual motivation. A link between vasopressin release and aggression has been closely observed in females, which may impair female sexual arousal and sexual motivation by leading to feelings of neglect and hostility towards a sexual partner. While exactly reverse is in males, that vasopressin is involved in the arousal phase, and high levels of this increase during erectile response and decrease back to baseline following ejaculation. The increase of vasopressin during erectile response may be directly associated with the increased motivation to engage sexual behavior in males, not in females. But this is my last slide. But for me as a sexologist and as a person treating the sexual problems in women, what I found was these are the real hormones which affect the women. That is, first is security. Whenever a woman feels secure, not only in a physical surrounding, but in emotional level also. When she is secure in relationship, it is said that the sexuality of a woman or the participation in sexual activity by a woman depends on many things. Even there are some mating principles also. People say that women will find a mate or a man who will protect us, who will care us, who will give security to her, who will give security to her children, and then she will prefer to have sex with that man. So it's not only her hormonal levels, but her emotional needs, her psychological needs, her societal needs, they are also very important in shaping up her sexuality or sexual behavior. Then comfort. A man can engage in sexual activity at any place for that sake, but woman can't. She has very restrictions, inhibitions, social obligations. So these are very important things. Now, if you take the background and sleeping behaviors as well as sexual behaviors in our society, many times even elderly people, they don't have privacy. So even in a menopausal woman, if a woman has sexual desire, but she doesn't have security and comfort to engage in sexual activity. Why I can say this very confidently is that nowadays most of the clients coming to our sexology clinics are in the age group of 50 to 70 years of age. Now, when these men like 50 to 70 years of age are coming to us for treatment, why they are coming to for treatment is their partners are ready to engage in sexual activity. And those partners must be 45 to 65 years of age. So will menopausal woman also has desire. Maybe the hormone level are less, but her psychological needs and desire is more. And that's why she is participating, allowing the partner to get the treatment for their sexual problems. So that is also very important thing. Security, comfort, and the performance of partner. That also is important for sexuality of a woman and sexual behavior of a woman and sexual desire of a woman. Love, care, these are most important things. Respect. In a male-dominated society like India, how many people, how many husbands, they respect a woman? Because women is very useful, I'm saying useful with a correct, my conscience is clear. We feel women is useful for all the house chores, reproducing children. So after menopause, sometimes male feels that now though there is a menopause, then there is no need of having sex with woman, despite she being, in fact, if you take a different view that now she is not at all bothered about menstrual problems, not at all bothered about pregnancy, she may have the sexual desire more than even in previous years. Very few women, but when they came, they confessed this to us. And that's why love, respect, and freedom is most important thing. We always say in female sexuality that what does a woman want? Not only in sex, but overall, is freedom. Let she be the decider of her own sexuality and see the change. Women's sexual behavior is most commonly or most oftenly controlled by a man. It is going hand in hand with man's sexuality. It should not happen. It is an independent behavior. So these are the real issues for a female sexuality. Of course, hormonal issues are also important because they are the basic things. But as far as all these interpersonal relationship and psychological issues are concerned, they also cannot be ignored. I rest my case here only about the hormones and sexuality in females. Thank you. Thank you very much. I stop.
Thank you, sir. Sir, I have one question. We understood how hormones play important role in libido. But is there any role of hormones as far as concerned to the orgasm or female orgasmic disorder? Is there any role of any hormones, particularly any?
Most importantly, estrogen is more important.
Same, like desire, it is also important for orgasm also?
Yes, orgasm. And second thing, they have said that oxytocin levels also should be proper in females. So that also is one of the things which has been not explored at all.
Right.
Sanjay sir, I just wanted to ask one question.
Yes.
Is there any difference of orgasm in premenopausal lady or menopausal lady? Is physiologically it is difficult to have the orgasm in case of menopausal and perimenopausal lady?
Maybe because in perimenopausal or postmenopausal ladies, it is said that the hormonal levels are less and people may have sometimes painful orgasm. But whatever is the experience from our patients, this is not a case because they really enjoy sexual activity. So whenever anybody asks me a question till what time a woman can enjoy sexual pleasure, I usually answer that women can enjoy a sexual pleasure till the time her partner is interested her and is able to satisfy her.
Absolutely. Absolutely, sir.
Yes, sir.
Thank you so much, Sanjay sir, for really wonderful insight of the topic. And really, we learned a lot about the hormones, role of hormones in the female sexual health and sexual function. Thank you so much, sir, for giving the
Thank you,
time.
thank you, sir. Thank you.
And
And thank you, Foxy, Sexual Health Committee, and Neeraj. I'm very happy to be involved here. Thank you very much.
Thank you for always
thank you,
being with us whenever we ask to present anything. You always comply without much because we know you are very busy, but and it's difficult to get time from your busy schedule. But you always agree for our talk. So thank you very much, sir.
Thank you, sir.
Thank you. Thank you so much, sir. Over to you, Queen ma'am, for the third talk. Yeah.
Thank you so much, Apurva. And so it is my proud privilege and thanking once again Neeraj sir for giving me the opportunity to invite none other than Dr. TSS Rao. We have had the privilege of hearing him umpteen times on our platform, and once again we are all ears. We are eager to hear sir because he enlightens us to a totally different level. After hearing him, we are always so enriched. So, anyways, without wasting any more time, we will invite Dr. TSS Rao, who is the professor of the Department of Psychiatry, GSS Medical College, Mysore, and the immediate past General Secretary of the Indian Psychiatric Society, apart from so many other feathers in his cap. So, over to you, sir.
And Queen ma'am, just to interrupt, sir is also going for the election this year for the president. So all the very best from all of us, sir.
Wow, wow,
We
that's
really
so nice to know. Best wishes, sir. So, over to you, sir. Sir, you
sir,
are
you have to
muted.
unmute
You are
yourself.
muted, sir.
Okay, 1 minute, 1 minute. You are able to see?
Yes, sir.
Yes, sir. Just minimize that right side. Yeah.
Okay.
No, sir, it is still there. Yes, you can just minimize that window, right side window on your screen. Yeah, yes, yes, sir.
At the outset, I am grateful to all the people involved in this particular program, and I've become so close with Dr. Neeraj and Apurva that anytime getting the invitation, I feel it is my honest, what we call privilege. I will take a little different route than what Dr. Vasan and Dr. Sanjay took. I believe that this particular program, a lot of endocrinologists are there. And if I try to talk about endocrinology as such, in fact, it may look pretty superfluous. Being psychiatrist, I'll try to make use of certain behavioral things what we come across. And majority of the things what actually Dr. Vasan and Dr. Sanjay mentioned, they have made my job simple for the simple fact that what I am going to talk, they have already brought into the focus one way or other. What I will be trying to look at is actually behaviorally speaking, what can be done. See, usually we take classes on biochemistry of sex, which actually runs for about 8 to 10 hours. So I have tried to condense myself to the extent possible. That way the topic can be covered in the best possible way in this that limited time that is available. Okay, 1 minute, 1 minute. This interaction happened, and one hormone or one chemistry, one molecule here, there, doing all the job. Again, it looks too superfluous from my point of view. There is biology, there is psychology, and there is sociology, and a lot of things are actually operating. People believe many of the times that it is actually in fact, the terminology screwing has come for the simple reason it is nut bolt phenomenon, something hardwired ideas people have. But we are all well aware. Actually, I was supposed to speak on teenage sexuality and hormones. It was modified for the simple reason that we thought many of these aspects would be covered by Dr. Vasan and Dr. Sanjay. So this is actually a whole lot of issues involved where a lot of chemicals get into the picture. And the point of this thing, Dr. Sanjay's last slide you must have seen, there are a lot of things which are actually far beyond what we talk about hormones. So when we are trying to talk about chemistry or sex, in fact, the love, intimacy, sensuality, many of these type of things have a real background of what we call as the chemistry. Sometime back when Dr. Madan was talking about chemical locha, this is one of the things what I had just focused. And what it actually means is, it's a potpourri of a whole range of chemicals which actually determine a lot of things. Why love works to be in some particular fashion to somebody. Why it is actually found as something very difficult. Invariably, the issue is it is actually pleasurable, something extremely important, and every living organism actually tries to go after it. Whether you're talking about amoeba to the very complex animal like human being, there are a whole lot of issues which are involved, which actually they take about what we call the chemistry, and a lot of issues get into the picture. So love means actually chemistry. So also the word actually the sex. It is the complex interaction of endocrine factors, neurotransmitters, neuropeptides on the one hand, and the whole lot of other actually behavioral issues. Those who are interested in reading about this, there is a very easily available book, Alchemy of Love and Lust by what we call Teresa. Extremely beautiful book. Every gynecologist and every psychiatrist and sexologist must read this particular book. Those who are proficient and want a little more, of course, there is a bigger book called Sexual Pharmacology, which deals with a lot of things. Look at the range of hormones which are actually available. Testosterone is called as Marlon Brando, the war hormone. I'll elaborate on a little bit later. Estrogen, Marilyn Monroe. Serotonin, internal schizophrenic. Whole lot of pheromones, sexual signal, what they generate. Oxytocin, which provides the hormonal glue. The PEA, the molecule of love. Progesterone, natural sex offender, but it actually functions differently in a different context. Monogamy molecule, the vasopressin, and more than anything else, actually the dopamine, which is exactly the executive neurotransmitter to testosterone. Each one has a very definitive role to play. I'll not go into elaboration at this particular point. If we try to look at brain and range of chemicals, they interact in a very significant way. There are certain areas where certain things are released, not only in the brain, at many other places, which are actually controlled by so many mechanisms. Important point here is actually there are few things which actually pro-erectile, pro-sexual. There are a whole lot of things which are anti-erectile. If we try to look at somebody is a opioid dependent individual, he is getting the high by opioids itself. Actually, in fact, the sexual functioning comes down so drastically. We talk about prolactin in our psychiatric practice, which actually produces a range of difficulty. But even in normal individuals, what are actually their role? So I'll not elaborate on these things, except that if somebody raises the questions. See, coming to testosterone, my approach is a little different. it promotes sexual drive, assertiveness, aggression in both sexes. It facilitates the action of dopamine, epinephrine, vasopressin. It inhibits certain things. What it actually does because of this is the range of sexual behaviors which it actually can determine. The point what I'm trying to convey here is there are some practitioners who actually having erectile dysfunction. Androgens are given without proper basic assessment and all. I'm not talking about endocrinologists. In fact, we actually refer a lot of cases to endocrinologists from that angle. The point is, androgens don't bring about erection. They just increase the libido. The carry-home message in this particular aspect is that if somebody is having erectile dysfunction, you give androgens and it enhances the libido, but he cannot get erection. It produces much more problem than actually what for he has actually had come up. We talk about sexual drive, both male and female. In many of the Foxy classes we have already spoken, men want more sex, they have more partners, have more sexual dysfunctions because of this. Women, lot of other things get into picture. Estrogen people were talking about, one of the important points is actually it's a receptive hormone, a passive hormone to a great extent, but could be active in its own sense. I'll elaborate if necessary arises later. But the range of difficulties come into the female sexuality because intercourse and intense pleasures are not linked. For many, it is difficult to achieve orgasm. Lack sexual frustration, lot of sentimentality, romance, and those are the things actually determined to a great extent. Traditional societies discourage duty than being pleasurable activity, and the range of hormones actually which influences. For this reason, desire for sex more often linked to the relationship status and social norms in case of females. At all ages, women are more likely to report sexual dysfunction. So just about few slides, because visually, in fact, it can carry the message. In case of women, it is love first and sex next. Testosterone, sex first and love next. Lot of behaviors, what we basically see men and many married women many times make complaint that you are dirty, you don't behave properly, and you don't have social etiquettes, and a lot of things actually what they talk about is related to the testosterone. Sensuality, watching, and in fact, many women actually telling their husbands, don't look at other women. Maybe actually they are cutting off the whole lot of these things. And one of the examples what I have given earlier also, one of our senior PG and another senior PG telling her that, see, your husband was watching girls on the way. Her comment was very simple. More hungry, that much better. See, many of these heroes, how actually they behave. And this particular picture I have focused again earlier also. See, even an extreme person like, say, Narendra Modi, Ivanka means his way of looking at is actually something totally different from actually the other presidents. Testosterone actually blinds to almost many of the things. In fact, many of the dangers actually people take. And many times, even whatever type of strict, rigid rules actually there's still a lot of sexual problems happen, not more that paraphilics to, in fact, antisocial activities happen, not because of anything, because of the testosterone. People have attributed to extra Y to increase the testosterone and all of that, but that may be a little controversial topic. Men feel bored because of a range of reasons, and in fact, the new partner, excitement, and which actually they take it forward to a great extent. And we are all well aware, hard porn is actually many men prefer compared to the soft other romantic, other related things actually what women like to. Where the whole lot of sexual assaults, harassments, and rape and other related things are attributed to the fact that actually the testosterone. This particular picture I just focused because, see, testosterone is released in the form of what we basically call pulses. It may be every 20 minutes to 30 minutes. When a man comes home, many times actually the woman actually becoming significantly angry, talking continuously and scolding him and all of that, it can actually trigger a whole range of what you call the interpersonal issues. If a woman is intelligent, you make him comfortable, bring the coffee while drinking, when that particular, what we basically call testosterone release is not there, this fellow would behave like what we call a duck or like a sheep. You can handle him whatever way you want it. This is one of the important picture, actually, the message what I just want to convey. Prolactin. See, there is a strong relationship between prolactin and what we call testosterone. Prolactin and testosterone, they are inversely related. In our psychiatric practice, what we do, we write so many antipsychotics and all of that. Each of them actually is capable of producing what we basically call testosterone. You look at, say, husband, in fact, the man, he gets aroused very fast, he ejaculates. But then for a certain length of time, there is a refractory period. This is attributed to the flooding of actually the brain with prolactin. And women, prolactin is there in plenty, basically, and in certain particular situations. In fact, the question came the nursing time and a whole lot of this time. In fact, the prolactin is so high, it can inhibit to a great extent the sexual feelings at all. It may be the nature's way of seeing that, in fact, that the baby needs to be nurtured. But the important point is actually the women are slow and they are like iron box. You put the plug on, they take very slowly to heat up. They can be multi-orgasmic, but this particular slow is attributed to some of these hormones. So women also feel like looking at men. In fact, people have attributed this particular fact to the testosterone. And women with low testosterone, this can actually create a significant problem. I'll come to that point 1 or 2 minutes later. There's a basic hormone called as dihydrotestosterone, DHEA, DHS. It is most abundant androgen, associated with sex drive, and especially in case of women, in strong association with exercise. What actually I'm trying to tell you, if a man actually does exercise for about 20 to 30 minutes, medium level exercise, the DHEA level has been found to be 2 to 3 times higher in those individuals compared to another one who doesn't do. Sex is a good exercise. In fact, one of the joking point is actually the cycling or sex, there is not much difference. One fixes the ass and moves the legs. In fact, that's what actually called cycling. Fixes the legs and moves the ass. In fact, this is what precisely called as sex. So there is a strong association, and this behavioral component I just wanted to convey. Look at estrogens. One of the important point is actually, though it is a passive, come hither. In fact, this is one of the important point, and it does a lot of things. It promotes lubrication. It brings about sexual desire and responsiveness in case of females, induces lordosis, bending. In fact, what actually has been attributed, there are some dance patterns where you bend the lady, that much more actually you can arouse. This jhatka, matka and all what you see in case of Bollywood. Men's dance, you might have seen it a little different from the women's. This is because the suppleness of muscles, which is actually brought about by the estrogen. Testosterone makes the muscles strong, and the movement actually significantly it is brought out unless it is practiced from the beginning. And this particular aspect is attributed to this. See, this is actually from the Bangalore Mirror, yesterday's paper. This particular lady is holding her hand near the vagina. This is attributed to the evolutionary component, wherein the woman, though actually she has the desire, but the dangers which are associated with are actually plenty. And actually, whether you are talking about animal or human being, they try to protect themselves. And more you actually bend the lady. In fact, this is attributed to, in fact, one can talk about this for pretty length of time. The vagina is brought to the closer aspects, and evolutionary wise, whole lot of things actually happening. If somebody wants to know about it, one has to have a lot of time to actually describe each of these type of behavioral patterns, what actually one is actually seeing in the whole this thing. Female inhibition is actually something extraordinary, and we have actually...
To my ever-loving wife, during the last year, I have attempted to make love to you 365 times. I succeeded 36 times. This averages once every 10 days. And the following is a list of reasons why I did not succeed. It's too hot, 15 times. It's too cold, 3 times. I'm too tired, 19 times. It's too late, 16 times. It's too early, 9 times. Pretending to sleep, 35 times. I'm not in the mood, 21 times. Mind my hair, 28 times. Is that all you think about? 83 times.
Basically, this has been attributed to the fact that some of the female sexuality is inhibited, and it is true. See, this is one of the very typical picture taken here, there, actually in the magazines. I have around 1,000+ photos related to in this particular fact. Man hoisting the flag, testosterone activity. Woman, estrogen, lock and key. Unless she feels comfortable about the relationship, she is not likely to actually cooperate. Whether an ordinary person or a celebrity, this particular thing actually holds good. That is almost under lock and key. And another point, what actually people have documented is, in case of man, all erectogenic tissues are situated in one particular place. Woman, it is slightly different. This is one of the reasons why actually the woman closes the eyes is one of the very typical, what we call any romantic situation, attributed to the fact that erectogenic tissues are distributed far and wide. Unless she concentrates, closes the eyes, and in fact, invests time on that, she is not likely to reach the peak. And whole lot of issues are involved in this particular process. And
लड़कियों का प्लेजर पॉइंट कहाँ पड़ेगा? चीज पर जाने का है ना, मैं बता दूं। यहाँ से बिल्कुल सीधा जा, इधर ही है, सीधा आएगा अपना वजीना नगर पे टोल आएगा, उधर ऐसे अपना पर्सनालिटी कंसेंट डेट लेने का, उसके बाद आएगा छोटा लाबिया गेट, वहाँ पे बहुत संभाल के चलाने का है, बहुत शुक्रिया। फिर फैलोपियन फ्लाईओवर अगर आगे ना तो तू बहुत आगे निकल गया है, तो वहीं पे गाड़ी घुमा के थोड़ा ऊपर नीचे आगे पीछे that spot right there keep it going, yes, oh yes, मतलब फिर बारिश होगी तो समझ के पहुंच गया।
तो वजीना नगर से स्ट्रेट।
बस ये लड़कों का प्लेजर पॉइंट कहाँ पड़ेगा?
मैडम यहाँ से सीधा जाने का एक बिल्डिंग पड़ेगा, एक ही बिल्डिंग, बुर्ज खलीफा टाइप।
बिल्डिंग से कहाँ?
कहीं नहीं, उधर ही आसपास कहीं भी, कुछ करने का भी नहीं, सिर्फ सोचो, फुल घनाघन
बिल्डिंग।
so, in case of man, it is easy. But in case of woman, it's a whole lot of different processes are involved. And you look at the hormones involved, progesterone, it is one of the depressant, unless it is actually associated with actually testosterone and estrogen. Can also lower testosterone levels, can cause depression, it can cause irritability, and a whole lot of premenstrual tension syndrome and other things what we talk about is attributed to this fact. And Dr. Sanjay was talking about mid-peak, enhanced sexual responsiveness. And another sexual responsiveness enhancement actually people have documented is actually onset of the menstruation. This is the time, possibly nature intended that it should have both pleasure and actually the reproduction should go, and this may be the reason. And this is one of the diagram I'm very fond of projecting here, there, everywhere, for the simple reason that fantasy alone, particularly in Indian context, people have documented not much, in the sense that many actually people feel guilty and actually fantasize significantly, and other men are a whole lot of such situations. In intercourse situations, only about 1/3, around 29 to 32%. And what we basically call touch is one of the most important component. And the inhibitory female sexuality, the whole process involved training the woman in what you call masturbation. If she understands her sensations, if she understands what actually drives her actually high, in fact, she can help the man in a big way. And this is one of the reasons why there is nothing like anorgasmia. With vibrators, almost 100% of the women can be taken to orgasm, though it may look exaggerated. This is one of the very important points. And men and female brain, there is a whole lot of difference people have. Predominantly preoccupation with sex is if the man's story, and a whole lot of other things, actually the woman's story. And people have documented what we basically call the PEA, phenyl ethyl amine. And this is one of the extremely important points. When we are trying to talk about aphrodisiacs, see, for example, loading the individual with plenty of chocolate, in fact, she can be in your arms. This is actually the things go. And there are a whole lot of what we call phytonutrients are available, which can be actually what we basically call aphrodisiacs, which actually enhance. Pheromones. I just take another 1 or 2 minutes to explain this particular idea that this is actually the gaseous molecule, very actually triggers. In case of the animals, it is actually one of the extremely important way how actually it attracts the opposite sex animal. Sexual intercourse, sleeping with a romantic partner, petting, affection, kissing, and a whole lot of such things are actually people have documented. Unfortunately, majority of the pheromones which are available in the market, they're all derived from what we basically call the pigs. The armpit and other areas where sweating is there, they generate plenty of what we call pheromones. Unfortunately, nowadays, we actually take bath every day, dress well, and a whole lot of makeup and other related things actually even men do. We may be actually pushing off the pheromones which are actually generated. I'll tell you, when we were actually doing our MBBS time, there were girls actually who would be more attracted to a fellow who is very rough and tough looking, doesn't take bath, and for pretty length of time. So, why this particular people attract the opposite sex is related to the pheromones, and which is actually there in plenty in our sweat. Because there are a whole lot of newer men, uber sexual and all what we talk about. That is one of the other area we'll talk if time permits. Vasopressin. See, then when you are trying to talk about vasopressin, this is one of the monogamy molecule. There are studies related to the prairie voles, which are actually about 5% monogamous, and what we call mountain voles, which are actually polygamous. And it all depends on the length of what we call vasopressin chain. If it is a smaller one, which is a longer one, actually, which can make a difference between a man actually settles with actually one woman to, in fact, he will be after many women. In fact, no man is a woman's hero. No husband is a woman's, no hero is a woman's husband. These are all few things. Unmarried and married can create quite a bit of difficulty for the simple reason that earlier the issues involved were a little different, and now the issues involved are actually a little different. The Spider-Man after marriage, even a very wild animal, once actually in the partnership, it behaves quite differently. These are all few of the things actually people have documented. And people were talking about oxytocin in particular. And please remember, oxytocin is necessary for female orgasm. And if we try to look at the whole lot of purposes it actually serves, attraction, touch, mating, sex, orgasm, bonding, labor, parenting, you name, in fact, majority of these behaviors are actually attributed to this. The initial romantic situation is actually the body sensation increases, almost like, say, for example, you are one is traveling and a nice, beautiful lady came and sat, and a little bit of touch can give that electric sensation. What we talk about is actually something attributed to the oxytocin effect. Marriage, what happens? For 7 fair hours, and at the end of it, this whole oxytocin effect goes off. And this is one of the reasons he was after me so much. Now it is actually not much. What many people actually complain is related to this. And in therapy, intimacy, sensuality, and other relations, what I talk about, if a man succeeds in treating the wife as girlfriend and novelty, in fact, it can bring about remarkable changes. Carry home message. Pro-sexual herbs actually does similar type of effect. There are few things which increase estrogen. There are few things which actually increase what we call testosterone. But there is a what we call happiness chemical. We come across quite a few ladies who come and tell us that everything is there. Money is there, and a very nice husband is there, and everything actually what we asked for. But all said and done, I am not happy. See, it is actually an interaction of many things. One is dopamine. Completing a task, doing a self-care activity, eating food, celebrating little job. In fact, being in a job, that itself can make about a whole lot of issues different. Serotonin. In fact, the deficiency of which it produces actually what we call depression. But to enhance serotonin, meditation, running, sun exposure, walk in nature, swimming, cycling, all these type of activities can add. Oxytocin effect, playing with a dog, playing with a baby, holding the hand, hugging a family member, give compliment, in fact, the partner, in fact, that can bring about. That last one, endorphin. In our body, we have certain chemicals called as autocoids or endogenous opioids, which have a significant effect to me. Laughter, exercise, essential oils, watching comedy, dark chocolate, exercising. There are 100 other such activities. Each of these things, how best actually one can combine. So the carry home message is actually somebody who can be physically fit. In fact, this is one of the extremely important for good mood. Excellent performance comes from excellent mood, and the partner can be. I can tell you one of the examples. Sometime back, there was a couple. Husband was telling, sir, she is always in the nightie and I don't get aroused. She doesn't take bath every day. When this issue came, the wife was telling, sir, please tell him I am not his girlfriend, I am his wife. Because you are wife and you neglect yourself can create problems. The partner can be one of the best known aphrodisiac for an individual. under stress. In fact, we all well
Rao
aware.
sir,
Over, na? They were and almost about a minute only. Cortisol
Okay.
can create quite a bit of difficulties, and giving what we basically call the relief from day-to-day struggle can make a woman responsive for the sex. In fact, all the hormones work better in that particular given situation. Bring about that man-woman magic. This is actually one of the important message. Thank you very, very much for giving this wonderful opportunity to talk to you. I have taken a little different route to go about. That is one aspect of it. And I also request all the gynecologists who have psychiatrist friends, please emphasize that Dr. Rob is contesting for vice president's post, and he need to be one. Thank you. Thank you so much.
Thank you, sir.
Thank you so much, sir. Thanks for enlightening us. It was so nice to hear about this from you. And again, wishing you all the very best for your upcoming elections
Thank you.
from our side. And now I would like to again invite my brother, Apurvo. Please take over.
Thank you so much, sir. Sir Rao, sir, your lectures is always eye-opening for all of us. So thank you so much for your valuable time for our webinars and your always blessings. So our next lecture is by none other than but very dear senior, a guide of us, Dr. Rakhi Singh ma'am. Ma'am doesn't need any introduction. Ma'am is the chairperson of the endocrine committee, FOXY. Ma'am is the vice president of UP chapter of ISAR. Ma'am is also on the governing council member of ICOG and what not. Thank you so much, ma'am, for organizing this webinar. You are one of the pillar of this webinar, always helpful for all of us. Thank you so much, ma'am. Over to you, ma'am, for your lecture.
Thank you, Apurva and Queen and Neeraj. We had a lovely webinar today with all the stalwarts with us, and I hope everybody enjoyed it. All the delegates must have enjoyed the different type of a webinar, and what actually sexuality and the hormones coming in harmony is important. And apart from then these all topics of sexuality and harmony, let's move on ahead and understand what is the male normal spermatogram or the normal morphology and the normal hormone acting on it, and where we go and how we go ahead. Basically, during infertility process, it is a couple what we need to see, and approximately 50% of the couple of the reproductive age group have the fertility problems, and because of the male factors, again the 50% or the 30% of the per se male subfertility is on the hands of the male, which is worldwide. And most of the people understand that, and it is known also. And adding to the complexity, there is a male that men typically do not seek healthcare unless it is an acute medical need for them. And as it is in the case of infertile couples, what we also know and what we have understood and learned over the ages in our OPD also, advanced paternal age is associated with increased risk for adverse perinatal outcomes for both the offsprings and the mother and the sexuality, what we know of also. And there are major lifestyle factors which are important to have being contributed to the hormones. There are various nomenclatures which have been assigned and given by WHO, which we all know of and understand of. And the parameters, what we earlier times we used to see, 10 years down the lane, the sperm volume was good enough of around 5 to 7 ml, what volume was normally given to us for the analysis in the labs of us, andrology labs. And the sperm concentration was way ahead. And I remember doing the semen analysis and the sperm concentration in the labs when we used to sit way back in 2004-5. And it was a huge task of counting good 150 to 300 sperms, which was a normal norm at that time, and which has decreased over the ages worldwide. And now the WHO parameters have come down to around more than 15 million. It is just 15 million, which was 300, 250, 200 million, 150 million. quite ahead and it was normal at that time. And definitely the fitness and the male factor plays a role, and there are various risk factors associated with the decreasing semen count and then the sperm count, which could be the drugs, the recreational drugs, the sleep cycle, or they could be the RO factors. There are various factors which are enlightened and highlighted. And when we talk about the prevalence of the male infertility, Delhi is at the peak, and which could be around 84% of the male infertility is seen. Ahmedabad is second in the study of around 76%. Then comes the Wardha, thereafter the Jamnagar, Bangalore, Kolar. They are all at one level. And definitely there was another retrospective analysis of 10 years which was carried out.
ये यहाँ पर इतने कार है खड़े, किसी का फंक्शन है लगता है किसी के यहाँ.
And it was found that around 35% only of the male factor were having normal semen sample, where sperm count, when compared to 64% having abnormal semen analysis report, which is quite high. And when we talk about that, as it is, which I have told, that in the last 70 years, there is a drop in semen volume and 58% decrease in the sperm production is seen from 1940 to 1990, which is there. And definitely we've been learning all this while about the main hormone which is responsible for everything, which is the testosterone. In the males, the falling testosterone is seen with the age factor, and as the male advances comes towards the late 40s or early 50s, they experience definitely a loss of sex drive, impotence, and depression. Vis-a-vis, I am talking when compared to all my previous speakers, what they have told us. And this is due to the natural reduction of the testosterone production from the body itself. By the time a man reaches 40, his testosterone will be approximately half of what it was in his 20s. And at 50, it would be around 1/3. And at 60s, it would decrease to 1/4 of the testosterone which was available to him in his early 20s. And definitely there is a declining hormone of testosterone as the age advances. And when we talk about the sperm morphology, definitely there are abnormality in the sperms. Either it could be the tail, the midpiece, or the head abnormalities which can be there. And these abnormalities definitely have again contribute to the fertilization and the capacitation of the fertilization effect, and again contribute to the infertility aspects. So there are multifactorial etiologies for the male infertility. Either it could be the age factor, which is at a problem, or it could be the lifestyle, or the pathophysiology, which could be a problem, or the environmental factors. There are all these factors which could be associated apart from the endocrine aspects, which could be contributing to the male infertility for us. And when we analyze the different causes of the male infertility, the problem, either it could be in the production of the sperm hormones, the hormonal control, which is at the hypothalamo-pituitary axis, or the problem could be at the blockage of the sperm, where the transportation of the sperm from the production house of the testis to the release and the ejaculation, there could be a problem. Or there will be a problem with the production of the sperm itself, and the erection and the ejaculatory problems could also be another problem. And there are various risk factors for the reduction of the fertility in male. Either it could be the idiopathic, which is 25%. Varicocele is coming up in a big way, which is 37%, and all the other factors are little less when compared to that. A word about endocrine, which we've been learning all this while from all the previous three speakers, and we are more wiser on it by now. And hormonal abnormalities of the hypothalamo-pituitary testicular axis are well recognized through not common causes of male infertility, extremely uncommon in male with normal semen parameters, and should be performed that any abnormal semen analysis, especially semen concentration less than 10 million, then we need to check for the impaired sexual functions or any other clinical findings suggestive of any other endocrinopathies. And GnRH is the hormone which is released from the hypothalamus. This acts on the anterior pituitary, thereby acting on the testis, on either the LH by the stimulation of the Leydig cells in the testis to produce testosterone, by FSH binds to Sertoli cell and stimulates the spermatogenesis, which is very important. And at puberty, both FSH and LH are required for initiation of complete spermatogenesis. Afterwards, the sperm production can be stimulated with HCG alone, but both FSH and LH are necessary to maintain the quantitatively normal spermatogenesis. And any symptoms which are suggestive of hormonal deficiencies? Yes, there are many symptoms which do suggest. And like whenever the male comes over here in the OPD, we need to check for the poor facial hair, the body hair development of that male, the decrease, ask him how many times does he require to shave, or any sexual dysfunctions if he is having, any gynecomastia, fatigue, depression, muscle weakness, osteopenia, and fractures if the patient has had small testes, or absence of male pattern of balding, or any other problems if the patient is having. We also need to elicit the endocrine history from these males, that whether the patient is on any of the diabetic drugs or having diabetes or any thyroid disorders. Check for Kalman syndrome. The Klinefelter syndrome is very important, where we can tell if there is a hypogonadotrophic hypogonadism and anosmia, then it could be a Kalman syndrome. And if the patient is obese, tall, and scanty hair and sexual dysfunctions are there, it could be a Klinefelter syndrome, what we are looking at. And for all these patients, we need to check for the serum FSH, LH, testosterone, and serum prolactin, which all of us have been importantly telling that these are the hormones which have to be checked on the males. A single measurement is usually sufficient. Many men with abnormal spermatogenesis have normal FSH, but a marked serum FSH is clearly indicative of abnormality in the spermatogenesis. The normal levels of FSH is required. Again, there's a understanding of it. What we know that the normal testosterone level in the males, the minimum is 300 and to 1200. If it is way less than that, then we definitely know that it could be the male factor because of the testosterone is a problem, or the prolactin level, if it is high, then again it could be a problem, which we've understood. A word about the genetic factors, lifestyle, and environmental exposures for these male infertility. Yes, genetic factors, lifestyle, and environmental exposures are important for the semen quality and the male fertility. Genetic factors may not only alone contribute to the sole cause for the decline in the dramatic environmental and the lifestyle changes that have occurred over the past few decades. Lifestyle changes like smoking, alcohol consumption in very large quantities, increased stress, and obesity all contribute towards a decline in the semen quality. And there are various environmental factors, like if the patient is in the high temperature zone, increase in the exposure of the ionizing radiation, excessive use of cell phones, or excessive use of radiations negatively impact these males over the semen samples. And definitely these are few of the reasons for the male infertility to be happening. And masculinization programming window, which is available, the timing of EDCs, that endocrine disrupting chemicals exposure, appears to be of a clear importance in male. It is clear that the fetal development period between 8 to 14 weeks in humans is extremely crucial for optimal fetal testicular development. And it is also known that the exposure of these EDCs prior to puberty can lead to adult diseases and the testicular dysfunction in the child. And there are various EDCs like estrogen triggering EDCs like anti-estrogenic chemicals like bisphenols, phyllanthrates, and DDTs, digoxin. The first and the few EDCs which were reported to act as endocrine disrupting, causing spermatogenic failure, were methylchlor and vincloxin. And these all, apart from these EDCs and the lifestyle factors like smoking, alcohol, diet, temperature, radiation, these all also have a major impact on the semen count and the semen analysis for the fertilization and the abnormality of the semen sample. There are various endocrine disruptors that are defined as chemical, which are present in the environment for the humans and the wildlife, that by the virtue of their ability to interact with the endocrine system are causing a variety of adverse health consequences. Endocrine disruptors are suspected to be linked to cancers and neurological, immunological, and reproductive diseases. The phyllanthrates are the chemicals widely used in the plastic industry. They are the testicular toxins and can mimic estradiol-like actions. And we all have learned till now that high estradiol is bad for the male and the sperms. So alkalinizing phenols and their derivatives have a variety use, including industry and the domestic detergents. They also have been shown to be estrogenic. Bisphenols, the estrogenic compound, again, a coat, dental treatments, and the coat of the medical containers, such as food cans, are also done by these bisphenols. There are various organic pesticides, the lindens, the DDT. It is now becoming clear that widely used variety of both man-made and the natural compounds are capable of mimicking estradiol and having anti-androgenic properties in the males and having problems. And these all EDCs, once they are exposed, the binding of these hormone occurs, which increase the oxidative stress, dysregulation of the receptor expression, and alter the testicular histology, and disruption of the steroidogenesis and hormonal metabolism, increase the sperm DNA damage, and epigenetic mechanism alter the sex hormones and the serum level. In the male infertility, they play a major role on it. There is definitely an impact, what we've understood till now, let it be the air pollutions, the chemicals, or the excessive heat on the sperms, and either they act by giving us decrease the sperm concentration, reduce the sperm motility, and abnormality in the sperm morphology is seen, and increase in the sperm DNA fragmentation is seen. Thereby, there is increase in the male factor of fertility. And there are various treatment approaches which are seen. We have to understand which patient the hormonal analysis has to be done and where which patient has to be treated. And antioxidant therapies, the ART, the ICSI, or the steroidal therapies, if it is an immune modulated systems, that has to be given, and the exposure to all the lifestyle modification has to be decreased. There are various drugs which are available for us to be treating the male factor only if the sperms are seen. Either it could be the clomiphene or the anastrozole or the letrozole or the tamoxifen can be given. And if the patient is having varicocele, then varicocelectomy, the transurethral resection of the ejaculatory ducts can be done, or the vasovasectomy. Or if these patients are suitable, then the ART procedures can be offered to these patients. If the sperm count is little within the limit, then IUI procedures or the IVF or ICSI can be done for these patients. To conclude, male subfertility is a significant issue that can have various causes and implications. It is crucial to understand that subfertility does not imply sterility. Several factors that can contribute male subfertility include hormonal imbalances, genetic abnormalities, lifestyle choices, the environmental factors, and certain medical conditions are important to rule out. And the major thing which is coming up nowadays is the lifestyle choices and the environmental factors, which play a major role nowadays. And while male subfertility can present challenge to couple attempting to conceive, there are various stages and interventions available to address these issues, seeking for appropriate medical guidance, making positive lifestyle choices, and considering assisted reproductive technologies can significantly decrease the chance of achieving successful pregnancy and parenthood. If they are not able to perform, then again, it's a major setback to them, and they again feel that they are not doing the right thing, and they fall into the trap, and then erectile dysfunctions also come into play because of that. And lifestyle, definitely, it's a major factor and plays a major role in optimizing the functions of the male reproductive system. And we have seen a major shift in choice of pertaining to a lifestyle in the past 50 to 100 years. And we have adopted more towards a sedentary type of a lifestyle and a lack of physical exercises and increase the consumption of alcohol, tobacco, which is playing a havoc in our life. So every couple, every male has to indulge into a regular exercise, cut upon the tobacco intake, and cut upon the lavish lifestyle of public drinking, and then just throwing up and showing that, okay, we are into the page 3 personality and we are into all these things, and lead a stress-free lifestyle, which is very important, and eat healthy. The burger, pizza cultures need to be stopped, because these, as it is, we are becoming the diabetic capital of India, and diabetes definitely plays a major role in for the male infertility. I would like to end my talk by telling butterflies may be better indicator of a health of our environment than birds. So see, where there are more butterflies, that is a healthy environment and free from pollution and free from pollutants. And that is where you know it is the right place. Thank you.
Thank
Thank
you,
you. Thank you so much, Rakhi ma'am, for really a wonderful and enlightening topic. And thank you so much. We really learned a lot today. And very rightly said, ma'am, we even in the sexual medicine, a lot of problems are there due to the lifestyle changes also. So thank you so much, ma'am, for really an eye-opening lecture. So
Thank
over
you.
to you, Queen ma'am, for our last topic for today by Hitendra Somani, sir. Over to
Thank you so much, Apurvo. So now I would like to invite Dr. Hitendra Somani. It's my proud privilege to invite him onto this webinar. And he is a DNB FICOG, FMAS, FIAGES, Diploma in Reproductive Medicine, and Joint Secretary, Indian Fertility Society, Gujarat Chapter, past President, Bhavnagar of OBGY Society, and he's from Bhavnagar. And without wasting time, I would like to invite you, dear sir, to kindly enlighten us on the issue of obesity related to sexuality. So thank you so much. Kindly take over.
Thank you for kind introduction, madam.
Thank you.
Okay.
Just make it PPT mode, Hitendra. You can just.
Okay, sir. Sir, my topic for today is obesity and its implications on sexuality. My special thanks to
Hitendra, kindly mute it on the slideshow mode.
Okay. Slides.
Up.
Yes.
Yeah.
Okay.
Click on that. Here. Start from the current slide, left hand side.
On top, yeah.
Animations के side पे है first slideshow.
Yes.
And then from the current slide. Yeah.
My topic for today is obesity and its implications on sexuality. My special thanks to Dr. Rakhi Singh and Dr. Neeraj Jadhav, sir, for giving me opportunity to present this talk. And thank you, ma'am, for kind introduction, and special thanks to Foxy also. So obesity is profound medical...
Sorry, Somani, to interrupt you, but still it is not in full mode. Just can you just make it in full screen mode?
Full screen, what it is?
Yeah, just
stop sharing and reshare it.
No, it is there only, but he has to make it.
I know, but he has to stop sharing it and reshare it. There was some problem.
Okay. Hmm.
Yeah.
Okay. Yeah. Obesity has profound medical, psychological, and emotional consequences, and it is associated with sexual.
These are also not moving it in.
Okay. It's not moving.
No.
In full screen mode, there is a in.
Either you can go down where it is written right side down 80%. Just next to it, there is one slide share mode. You just click on that.
80%. 80% is where?
Go at bottom.
So to your bottom right side.
Bottom right side. 80% है ना? Plus minus. Below slides. Your cursor is not to be seen. Press escape.
Press escape.
स्लाइड शो आया ना बॉक्स, उसको करो ना एक बारी. बॉक्स आया ना ऊपर ओबेसिटी के साइड पे स्लाइड शेयर.
No, it's not coming.
Press escape once.
Okay. Slideshow.
No, go down. Go down. Down, right side, the other end.
No, we are
Minus is there.
not coming.
82% है ना, उसके साइड पे है.
82% आ ही नहीं रहा है. देखिए.
एकदम बॉटम पे.
एकदम बॉटम पे है.
तुम्हारा लोगो है उसके नीचे.
उसके नीचे देखो.
लोगो के नीचे. हाँ.
There is 82% के साइड पे है ना, उसके सामने.
It is not. I cannot see that 80% is written.
Okay.
Can I go?
Can you continue like this only? No problem.
Can you see my slides?
Yes, slide is in. No problem. You can continue like this. No problem.
Continue like this only.
Okay. I'm sorry for disturbances. If you look at WHO definition of 2015, obesity is excessive accumulation of the fat, which poses a risk to the health. So this obesity may be divided according to the BMI. If it is 25 to 29.9%, it is overweight. 30 to 34.9 is class 1. 35 to 39.9 is class 2, and 40 or more is extreme obesity. The prevalence is almost 50% in adult urban Indians, and 29% of the children, they belong to this criteria of either overweight or obese. Which are the risk factors for obesity? Mainly there are three: the food intake, metabolism, and energy expenditure, and physical activity. Any disturbance in this will cause obesity. So which factors can cause this disturbance? That is overeating, which may be due to socio-cultural, lack of knowledge, peer pressure, uncontrolled eating, hunger, emotional eating, snacking, lack of sleep, and medication. It can be due to low energy expenditure. So it happens because of aging, sex, genetics, epigenetics, neuroendocrinal factors, brown fat, and it can be due to physical inactivity like socio-cultural, physical, chronic fatigue, muscle pain, joint pain, low fitness, and emotional reasons. So any disturbance in this will give rise to obesity. All of these
are... Mani, we are not able to see your slide. This is only one slide is there. Next slide we are not. You have to move that slide also, left side.
Can you see now?
Currently, slide number 5 is on view.
This is slide number.
You have spoken further. Only slide number 5 is in view.
It is not moving?
No.
Now it is moving?
No.
Now?
It's stuck at slide number 5.
Okay. It's moving.
Now it has changed to slide number 8. Yes.
Fine. So again, the sexual health, according to 2006 WHO definition, it may be defined as mental, physical, and social well-being in relation to sexuality, not merely just an absence of disease, dysfunction, or infirmity. The sexual health requires a positive and respectful approach in respect to sexuality and sexual relationship, and as well as the possibility of having pleasurable and safe sexual experience, which is free of discrimination and violence. The sexual dysfunction, there is no universally recognized definition, but according to DSM-5, it may be defined by disorders of desire, arousal, orgasm, and pain. So, clinical picture of various types of sexual dysfunction in men and women may be sexual desire dysfunction, persistent sexual arousal dysfunction, orgasmic dysfunction, sexual aversion, sexual arousal disorder in women, dyspareunia, vaginismus in women, erectile dysfunction, early ejaculation, delayed ejaculation, and
not moving.
It's moving?
No.
So we're still on slide 8. It's not moving. I think, sir, if we don't have an option, you continue speaking, we will just hear you. The slides are not visible. Neeraj, sir, what do you suggest?
Can I share it again?
It is still at slide 8. It is stuck at slide 8.
Kendra, and don't put it on the slideshow mode.
Okay, we'll just go on small scale. Skip kar dijiye. ठीक है, now it is visible?
Yeah.
Yes.
Yes,
Yeah.
yes.
11, yes.
Fine. So prevalence of sexual dysfunction is 40 to 45% of the women, and 20 to 30% of men have at least one type of sexual dysfunction. So if you look at different evidences, there is a strong evidence to indicate that obese people have sexual dysfunction. With reduction in weight, there is improvement in sexual function. With reduction in BMI, according to different studies, there is an improvement in sexual function. And also with changes in lifestyle, there is an improvement in sexual function. Weight reduction causes improvement in sexual function in terms of arousal and orgasm scores. So in obese men, they are twice likely to sexual dysfunction, and they are twice likely to have infertility problem. So they have more double incidence. So if you look at the relationship of sperm and BMI, with increase in BMI, the sperm concentration decreases. Various meta-analysis of 21 studies shows risk of oligozoospermia is more in overweight and even more in obese patients. If we look at different studies of 2012, where the markers of sperm markers, with increase in oxidative stress and DNA integrity, there is twofold decrease in sperm mitochondrial activity. With increase in oxidative stress in obese people, there's a decrease in sperm quality. With decrease in DNA integrity, it is also found to be increase in obese men. And apoptosis and proteomic changes are more seen in obese men. So what are the changes in the semen in men because of obesity? There's a decreased sperm count, and there is a decreased sperm function and proteomic functions. So in obesity and in obesity of men, basically it may be due to physical disorder, it can be due to genetic disorder, it can be due to hormonal disorder, which in turn causes erectile dysfunction and altered seminal parameters, which leads to infertility. In case of male, the levels of adipose cells, the levels of leptin, adiponectin, and resistins are decreased, which are involved in glucose metabolism, sexual maturation, and reproduction. And there is also excess leptin decrease in Leydig function, and also increase in level of the IL-6, IL-10, TNF-alpha, which increases nitrous oxide production and oxidative stress. So what are the mechanisms? There are three main mechanisms. One is oxidative stress, second is hormonal imbalance and hypogonadism, and accumulation of the endocrine disruptors. So treatment modalities in such cases are lifestyle and nutritional changes for obesity, like diet and exercise, pharmacological intervention for obesity can be appetite suppressors, weight loss like orlistat, aromatase inhibitors, surgical interventions like bariatric surgery, scrotal lipectomy, and ART like IUI, IVF, and ICSI. If you look at obesity in female, the female, they're 3 times more likely to have sexual dysfunction because of obesity and 3 times more likely to have infertility problem. So chances of pregnancy is reduced by 5% for every BMI unit that exceeds 29 kilogram per meter square. So basically, which are issues of female associated with infertility, and they are incidence of irregular obesity and infertility. There are incidents of many irregular menstrual cycle, problems of ovulation, increased time to pregnancy, increased androgen level, PCOS, risk of miscarriage, and risk of major pregnancy and delivery morbidities. So by which this mechanism, this obesity and infertility are linked by mechanism, and they act at every level. They act at the follicular level, cause the atresia, delayed meiotic maturation, increased aneuploidy rate, increased follicular apoptosis, whereas endometrial level, they decrease decidualization and receptivity, decrease gonadotrophin levels, they increase leptin, TNF alpha, IL-6, free fatty acid, androgen, and estrogen, which in turn increases insulin resistance and hyperinsulinemia, which gives rise to infertility and obesity. So both of them are very much overlinked, and obesity is strongly associated with PCOS. The main central players are insulin resistance, hyperandrogenism, elevated leptin levels, and leptin resistance. So underlying mechanism is basically both seed and soil become defective because of anovulation, the oocytes, which is not optimum, and endometrial abnormalities. So PCOS becomes a leading cause of infertility in obese women because of the increased resistance of insulin, hyperinsulinemia, increased androgen, oligoanovulation, cycle cancellation, and risk of miscarriage. There is a reduced chance of SHBG level, menstrual cyclicity is reduced, ovulation rates are reduced, and response to gonadotropin is also decreased, and success rate of ART is also decreased in those patients who are having obesity with PCOS. What are the effects on oocyte? Now, this obesity causes effect on early follicular atresia, delayed meiotic maturation, increased aneuploidy rate, and increased follicular apoptosis. These oocyte effects are done by basically by lipotoxicity, increase in reactive oxidant species, and apoptosis. And this gives rise to stress, which leads to apoptosis, which is evidenced by elevated levels of free fatty acid in follicular fluid. Correlates with the morphologically abnormal oocyte complex. Which are the effect of obesity on embryos? These obese women are likely to have poor quality embryos, and embryos become more susceptible to lipotoxicity, and there are elevated levels of leptins. So when we are treating female obesity and infertility, please tell them to keep it. When we are treating female obesity and infertility, the lifestyle changes like nutritional changes, diet, exercise, psychological counseling. The second can be done is that pharmacological interventions like appetite suppressions, use of orlistat. These drugs increase the suicidal tendency, and metformin is not a weight-losing drug. We can take a help of ART like IUI, IVF, ICSI, and surgical intervention like bariatric surgery can be done in female with obesity. So in conclusion, obesity is associated with lack of enjoyment, lack of sexual activity, lack of sexual desire, and difficulty in sex performance, and also the avoidance of sexual encounters. One of the conclusions is that obesity has been shown to be associated with chronic diseases, psychological disorders, as well as depressive disorders. Thank you for multiple disturbances. I'm so sorry.
Part
No,
of
sir.
not issue.
In spite of the multiple disturbances, I'm sure even Dr. Neeraj Yadav sir and Dr. Aki Singh will agree that it was a wonderful talk, and like men are 2 times more susceptible to all of the problems and women 3 times more. This is a lesson that we have learned, though we all knew that there was some correlation, and so we all should keep away from this dreaded disease or epidemic which is called obesity. So thank you so much, Hitendra sir. And over to
Purva, are you there?
Yeah.
Yes, sir. Yes, sir. I'm there. Yes, sir.
So over to Apurva now.
Yes, sir. After this wonderful session and talks on endocrinology, role of endocrinology in the sexual health, now it's the time to say goodbye. So before I give the vote of thanks, just thanks to our Foxy President, Secretary, Vice President in charge, Dr. Asa Bakshi ma'am, and Dr. Gitendra Sharma, Madhav sir and Dr. Raki Singh ma'am. Without their effort and without their blessings, this can't be possible. Our faculties for today, all the wonderful speakers, Dr. Vasant sir, Dr. Sanjay Deshpande sir, Dr. T.S.S. Rao sir, Dr. Raki ma'am, and Dr. Harendra Somani sir for the wonderful talk. I would like to thanks to the ICOG chairperson, Dr. Lakshmi Srikhande ma'am, and Dr. Ashok Kumar sir for giving us the one ICOG credit points. I would like to thanks to my co-moderator, Dr. Queen ma'am, for wonderful moderating this whole webinar. And I would like to thanks to all the to all the audience which are still glued to their screen and make this successful one. So thank you to all of you for attending.
And thanks to our Medicine people also who are telecasting this webinar on their application, that is Message app. So thank you for joining us. Thank you, Raki, for making this possible. I hope everybody enjoyed this fantastic webinar.
It was great associating with Sexual Medicine Committee, which has been very nicely nurtured by Neeraj, and he really enjoyed the whole webinar. I hope all the delegates have nicely benefited us. It was like a big jolt to me when Raki, we have to do a webinar together, and everything became blank for me. I had to recoup from stating and thinking that what topics it can be covered. That is only sexual and endocrine, and really turned out to be a beautiful one. Thank you, Neeraj.
Thank
you. Thank you so much. Thank you.